right, let's go ahead and get started. So good morning, everyone, and thank you for joining us today. As I mentioned, in the interest of time, I'll go ahead and get it started. We do have some presentations. So my name is Juana Zendejas. I am the supervisor for the Communicable Disease Investigations Program here at the Fresno County Health Department. So we do follow up on the outbreaks in skilled nursing facilities. So if you've had an outbreak, you have worked with my team. We are bringing back the skilled nursing facility quarterly calls. We intend these to be educational and cover a wide range of topics that will benefit your infection preventionist and your facilities. We also are working with CDPH to do these regionally with our neighboring counties in the efficiency of time for you all. And so we can all be on the same page and communicate well. So stay tuned for that. On the call today, we have our consulting physician, Dr. John Schweifler. You may remember him from the past quarterly calls that he would do with the skilled nursing facility. So he will be presenting on the COVID policy updates. We also have our infectious disease controller, Dr. Al Zagbini, that will be presenting on MDROs and enhanced standard precautions. If time permits, we will leave some time for questions. You can also leave your questions in the chat box. I will also put my email address in there, and you can use that as a contact for us. And I'll leave our email for our nursing liaison, Latoya. I'll put her in there. And of course, if you need to reach our CDI program, you can always call the 559-600-3332 number. We have a person in the morning and then the afternoon that is available to answer whatever questions that you may have. So I will go ahead and turn it over to Dr. John Schweifler so he can get us started on the first presentation of the day.
All right, thanks, Juana, and good morning and welcome to everyone. Thanks for joining us on this SNF update. So first of all, an announcement. So CDPH put out an AFL regarding family councils. So you are expected to make available the option for family councils at your skilled nursing facility. And it's a place where members and their families can meet in private without facility staff. And you're expected to at least allow them to have a meeting room where they can do this at least once a month. This is not required by CMS, but again, it is a requirement from CDPH. In terms of next, we'll talk about COVID updates. And so just a reminder that the COVID was very real. And I know there's just a lot of misinformation out there. Let me see if I can do one thing here. Yeah, so if you just in terms of overall deaths in the United States, so they are pretty stable year over year, around 2.8 million. But in 2020, that jumped up to 3.3 million. An additional 500,000 people died in 2020, and we saw similar numbers in 2021, 22. So over 1 million people have now died from COVID. In this particular year, you can see deaths from other leading causes of mortality remain stable, but COVID appeared. So the last time we had a jump like this in mortality was back in 1918, that when World War I was being fought, and when we had the first, the Great Flu epidemic, where we saw an increase like this in terms of deaths. So COVID, very real. Thanks to all of you for all the work you did to help take care of our most vulnerable population during this very difficult period. So we're starting to wind down a lot of the COVID requirements. So just to go over some of those changes. So CDPH made changes to its face covering guidance, so this went into effect on April 3rd. So it's in effect now. In a nutshell, face coverings are no longer required in healthcare settings. However, it is they do have recommendations that are tied to community levels of transmission. These community levels of transmission are identified by CDC. So if you go to this website, it'll take you to a website that will show the levels of transmission. Currently, our levels of transmission are low. In Fresno County, so these are updated on a weekly basis. And what CDC says is when it's low, you can consider using masks. If you get to moderate transmission, they recommend using masks, and if it gets to high, they strongly recommend a high transmission. But again, they're not required. The individual SNFs can healthcare facilities can establish their own policies regarding masking. And our recommendation is that you really take into consideration the Cal OSHA aerosol transmissible disease guidelines as you think about face masks in your settings. So particularly if you're dealing with someone with respiratory symptoms, so cough and fever, mask for source control for patients, and mask for everyone who's in contact with those individuals. In terms of immunizations, again, CDPH as of April 3rd is no longer requiring COVID vaccines for staff, and you're no longer required to test individuals who are not vaccinated. However, CMS still did require vaccinations and boosting for COVID if you want to get paid by Medicare or Medi-Cal. So for just about everyone in a skilled nursing facility, even though the CDPH guidelines requirements for immunizations have changed, if you want to get paid by Medicare or Medi-Cal, you still need to be to have your staff fully vaccinated and boosted. In terms of isolation and quarantine, just to summarize, this is for the general public, so this is not specific for skilled nursing facilities. So what the guidance is now is if you do have COVID, you're supposed to isolate for 5 days, and as long as you're feeling better after 5 days, you can end isolation. It's recommended that you wear a mask through day 10 while in public, and that if you're a close contact, you no longer have to quarantine, but it is recommended that you test it 3 to 5 days. Both of these are recommendations; they're not requirements for the general public. CDPH does there's specific guidance for both healthcare workers and skilled nursing facility residents that are described in the AFLs, and I'll go over that in this slide. So in terms of what happens with isolation, quarantine, and skilled nursing facilities, it's different than what it is for the general public. So for staff, you're supposed to, if you're positive, isolate for 5 days. But unlike the general public, you're required to have a negative test prior to returning. And you're expected to wear a fit tested N95 through day 10. If you're a close contact or exposure, you're no longer required to quarantine. However, you are expected to test upon exposure and then repeat tests at 3 to 5 days. For residents, it's different. So your residents are expected to isolate for 10 days. If you're a close contact, the expectation is that you do an immediate investigation. You don't have to test everybody on a unit, but if you identify individuals who are close contacts, roommates, etc., then those would be the ones that you would be recommend testing for. And similar to what we see for staff, test promptly and on days 3 to 5. Those who are exposed do not need to quarantine, but source control, i.e. face covering, is recommended when they're outside their room. And it's a similar testing recommendation for new admissions to skilled nursing facilities. So kind of subtle differences between what the requirements for staff, for residents, and different from the general public. In terms of what's considered an outbreak, well, yeah, first of all, when would you start to do investigation for COVID? Well, if there's any cases, so 1 or more, then we do expect you to be investigating. When do you report? You're still expected to report if there's 1 or more probable cases, and then we would consider it's as an outbreak if you have 1 or more. So there's some kind of other specific situations that are also described in this slide, and we'll get you this information afterwards so you can look at it, have it as a reference. In terms of visitation, so per AFL 2107, you're no longer required to test or to require have proof of vaccination for visitors. And face coverings are also no longer required, but you can establish more stringent guidance. And just to reiterate what's said in the AFL 2207, there's really an emphasis on on ensuring that that family members, loved ones are able to visit. So failure to facilitate visitation with adequate reason would constitute violation of residents' rights. Right. So you want to err on being able to provide some options for visitation. And some ways you might consider this, because with COVID, it's really highlighted that some patients and families are going to be very risk averse and really want to make sure that they're masked and everyone around them is masked, whereas others are much more flippant about it. So you just, I think you need to be prepared for both. So one way to do that, continue to post screening questions and regarding COVID symptoms, cough and fever, and reschedule visitors with cough or fever on day of visit or if an isolation period for COVID. Think about either having separate sections where people who are masked versus those who are unmasked can stay, or flexible times where, again, masked or unmasked might be available in common areas, say from 3 to 4, and then different group from 4 to 5. And if you're in double occupancy or more rooms, then if a roommate is uncomfortable, then visitors should be masked. And then always that outdoor visitation much safer to prevent as far as reducing the risk of transmission for any type of respiratory transmission. So that's a quick run through, and with that, I'll turn it over to Dr. Al, and feel free to put any questions in the chat and we'll try to answer them there.
Very good. Good morning, everyone. You hear me?
Yes.
Okay, very good. I will, let me see, maybe I could share my screen so I could control better.
Okay.
Okay, you see my slides?
Yes.
Okay, very good. So, my slides will be mainly about multi-drug resistant organisms. I will talk a little bit more about the CPO, CRO. This is much more like the carbapenemase resistant organisms, the carbapenemase producing resistant organisms. And I'll talk a little bit about the Candida auris that probably you hear about it in the news, and you've seen it probably with the new health advisory. And then I will talk about ESP, the new way of preventing transmission of these multi-drug resistant organisms that has been more pushed to implement it in the nursing homes. So multi-drug resistant organisms has been, as all of you know, in nursing homes, especially the infection preventionists, like this has been the names that we have been seeing over the years, MRSA, ESPL, it has been there for a long time. And in 2013 was what the CDC considered to be a threat for public health, because there have been rise with the older players and with new players in public health. So most of you probably remember the MRSA. MRSA initially was discovered in 1961. So just 20 years when penicillin was implemented and for commercial use. So it didn't take much for the Staph aureus to be a resistant organism. And then ESPL came in. ESPL is much more extended beta-lactamase. So here you're looking for not just penicillin resistance, but most of the cephalosporins, bigger gun than penicillin. And then the third class of the antibiotic, which is the carbapenem, this is much more like ertapenem and meropenem. We start seeing the CRE, the carbapenemase or carbapenem resistant enterics, and the KPC. This is kind of the first one that was discovered in 1996, and it didn't take long until NDM, which is kind of the one that we have been dealing with outbreaks in 2008. So what are multi-drug resistant organisms? You know, each type of bacteria has some class of antibiotics that will will kill it. And the minute this particular class, if it's penicillin, cephalosporin, vancomycin, that bacteria will be labeled based on the resistance to that particular class of antibiotics. So MRSA, considered in history to be one, VRE, vancomycin resistant enterococcus, and then the new players that we hear now about CRE, carbapenem resistant Acinetobacter or the CRAP, and the Pseudomonas aeruginosa or CRPA. Why do we care about multi-drug organism in nursing homes? You can see that this is not based on theoretical analysis. It's based on some testing that has been done. And it's speculated, like usually a regular SNF will have about half, a little bit more than half of the resident having these organisms, not necessarily sick from it, but just colonized with it. And this number goes much higher to 3/4 if you're having a ventilator SNF or subacute SNF. Why SNF residents or nursing home residents are at higher risk to acquire these infections than somebody from community or somebody maybe who's in and out of the hospital and going home? Different reasons. You have different exposure to antibiotics. Most of these patients, as you know, they keep going back to the hospital, they're sicker. And overuse of antibiotic, in addition to having more, foreign bodies, lines, catheters placed, this will lead to these bacteria to have a little bit better environment to multiply and be colonize these hosts. To make things more complicated, the same numbers that the other slide showed, that, hey, 50%, 76%, this is mainly without testing. When we test or the confirmed people with testing, look at the numbers. I mean, 17% are confirmed tested patients, and you still have large number of these patients are not tested, but they are just colonized and undiscovered. And the same thing here. I mean, you're having 20% documented or confirmed, and you have large percentage of these residents are truly colonized but not tested. And why is that? Because testing, hey, it's not available. It's not commercially available for everybody. It's a little bit harder to implement who should test it and who should not be tested. So these numbers tell you that you have large percentage of your residents infected or colonized with these multiple multi-drug resistant organisms. They potentially could be transmitted these type of resistance to other patients without knowing what we have. This slide also summarizes what I said, that usually if you cannot wait for some patient to go to the hospital and have a UTI and the culture shows that they have this particular resistant organism, you're just simply looking at the tip of the iceberg. Most of the large percentage of these patients who carry these resistant organisms are undiscovered because they're asymptomatic. They don't require usually testing because they are not sick from it. Similar to what we've seen with COVID before, right? You have some people who are not really sick from the COVID, but they could spread the disease. But here you're talking about much more dormant infection of some sort. People are not sick from it. It doesn't give you any acute symptoms immediately. Most of these patients are chronically colonized with these organisms, and they're silent spreader. And usually, why nursing home, again, is a high risk environment? Number one, the resistance. So you're given more antibiotics, right? You're having somebody with a catheter. They get confused. We get a urine test. A urine test shows something growing, probably unrelated to the symptoms that the patient had. We throw antibiotic. It's easy to give antibiotic to nursing home residents for any minor symptoms that might be not related to the infection, and this will lead definitely to acquired resistance. This particular enterococcus that was good for penicillin today, hey, next time you're gonna check the urine, it's going to be immune to it, and you're going to try another antibiotic. And the story goes on and on. And then, as I said, many of those patients are asymptomatic silent spreader. So sometimes you wonder why this patient had this resistant organism, if they never had any antibiotics before, because simply you could have a roommate that has the same bug and gave it to the other person who never been exposed to these antibiotics. And the transmission, if you don't know that this patient is colonized with this particular infection, and you're not doing some precautions to stop the spread, this will lead to more spread in that particular environment. And we're not looking for one environment. Most of these patients, I mean, they move, right? They go to dialysis unit, they go back to the hospital, they move to another facility, acute care hospital, and so forth. So this cycle of spread becomes just unstoppable. And this mode of control and containment has been there for some time. Like anytime you're having a new novel organism, I mean, you try to detect the case. Most of these folks are usually in a hospital setting. You try to control the infection by doing some PPE and infection control measures in the hospital. And then when the patient moves to nursing home or step down unit, and then you try to find their contacts, tracing and testing those people you consider to be at higher risk to acquire the bacteria. So far, these are considered, based on the CDC definition, to be the novel MDRO. These are the ones that we care about in a hospital setting and we care about in a nursing home. So the older players, the MRSA, the BRE, it's kind of a little bit of a history most of the time. I mean, they go to a hospital, permanent contact isolation, a nursing home. What we care about is the new carbapenem resistant organism, and that will acquire some bug that's resistant to all the the antibiotics you have, and the CRE, the CRPA, the CRBA, crab, and the Candida auris. Why do we care about MDRO? Number one, because they could result in an infection. So this patient who had today CRE in the urine or in a wound, and maybe they're asymptomatic, potentially they could the next week, month, could get infected with this. It could go to the bloodstream. They could die from it. It's higher resistant to antibiotics. So the treatment options are very limited. And number two, it's transmissible. And this is kind of where the public health concern is, that you might be asymptomatic, but you might give it to somebody who has no exposure beyond that roommate that was infected with. These MDROs, they will not make everybody sick, but the type of the patient who got colonized with the MDROs are already sick, right? Your typical patients with a ventilator, with PICC line, with Foley catheter, they're dependent on others. So to start with, these are higher risk patients. These are the same type of patients that had COVID, increased mortality in the nursing homes. There will be the same type of patient that have higher risk for morbidity and mortality from the MDRO. And again, the tip of the iceberg, right? These organisms, they move back and forth, different environments, and this will lead to more cases. And many of these cases when we see somebody who is colonized with these, most of the time, these folks are colonized for a long time. And usually there's not much, MRSA is the only one that they found some decolonization method. But most of the gram-negative or the fungus infections, there's no really medication that you could say, hey, give this antibiotic, the antibiotic will remove this organism from your body. Most of these patients, when they get discovered to be colonized with one organism, they stay colonized, if not indefinitely, for a long time. Again, the difference between colonization and infection. An infection, you're sick from it. You have a UTI symptoms, you have a pneumonia. Colonization, mainly, you simply carry the bacteria. It's in a dormant stage. You're not, you look healthy, you behave at baseline, and you're not really sick from it. And the colonized patients are much more at the bottom of this iceberg. It's the large percentage of these patients that spread the infections. So CRO is the carbapenem resistant organisms. And these are mainly, either you discover this by doing a culture where you find the bacteria Pseudomonas, Acinetobacter, Klebsiella, E. coli to be simply resistant to ertapenem or meropenem. Or if you have a PCR test of some sort and it shows that there's the enzyme, the carbapenemase, positive, and you don't have a culture, either one is considered or labeled as a CRO, carbapenem resistant organism. And carbapenem resistant organisms, some of them are carbapenemase producing organism, meaning the mechanism for this particular organism to be resistant to this particular carbapenem antibiotic is by producing an enzyme, and this enzyme will degrade that particular antibiotic. There are different mechanisms for the resistance to acquire resistance to carbapenem antibiotic. But if you have an enzyme is like a bullet. It's the most effective way for this organism to make this particular antibiotic ineffective. So if you have an enzyme that's discovered by whatever assay the lab has, these are the one that we're concerned about. These are the one that's super contagious. They could spread much easier and potentially could lead to an infection down the road. These CPO, the carbapenemase producing organisms, the 5 big players that have been causing these outbreaks, the KPC, as I said, this was discovered in 1996, so it has been there for some time. NDM, we had our share here in the state and in Fresno with some outbreaks related to it. This was discovered in Sweden in 2008, and the OXA is the one also we had some of our subacute rehabs here. We had outbreak related to it. So not the NDM is the one that was concerned about with the outbreak and health alerts and so forth, because most of these enzymes, each one has a little bit more potential for spreading compared to the other. So again, the most important thing for any carbapenem resistant organism is, does it produce the carbapenemase enzyme or it does not? And usually, most of the time in a hospital setting, when you have a culture showing this particular E. coli or Klebsiella resistant to that antibiotic, there's another test, which is the carbapenemase testing to see if that's present or not. And if that's present, then the infection control measures will be much more strict, and the placement and so forth will be also a little bit different. You could see from this that the carbapenem resistant organism has been spreading in big wave from 2001 to almost started in the East Coast, and now we have like almost every state has these infections. And again, different organisms with different enzyme. So if you look at the slide here and you look at the CR, the carbapenem resistant organism in California, I mean, it's a scary number, right? If you look at the enterics, we're talking about E. coli, Klebsiella, Serratia, and so forth. It's about 50% of these are carbapenemase producing organism, meaning they're very transmissible and contagious. The crab one, the Acinetobacter, is much more contagious. And this is kind of where we had also more concerns recently about the crab outbreaks. And in Fresno here, we had our share of these outbreaks, about 50 to 90%. Pseudomonas, not too much. Pseudomonas tends to be kind of less virulent or less transmissible compared to the other 2 gram negatives. And you could see, I mean, the Central Valley, San Joaquin Valley, it did have much more crab cases, which will make it kind of more concerning about the infection and spreading than the others. And it's probably much more in the Central Valley than if you go to the other regions in the state. And the same thing here, like this did not really leave any, Fresno is here. This is a little bit older slide. We have more cases there, but almost every county has its share of different, of course, the bigger counties, they have more cases. So that's the CPO CRO. And then the Candida auris is the one that there's too much concern about it, the super fungus. You could see these articles that been published over time. First of all, the first case was discovered in Japan, 2009. And it didn't take much until it arrived to the US in 2016. And the slide from the CDC, since then, it showed like the concern about the rising cases worldwide. 4 different regions that spread to the US. Why we care about Candida auris? Candida, as you know, it's a common fungus that we tend to have it in our skin. It's environmental. It's easy to treat. It could give you some infections here and there. Definitely, it will be worse in immunocompromised patients, but there's a cure for it. Most of the time, these Candida strains, they have response to different antifungals. The Candida auris in specific, it's much more unique. Number one, it's new. Number 2, it's drug resistant, similar to the CRE and CPO. It has some resistance to the typical antifungals, and if it moves from the colonization to the infection stage, high mortality there. And to make things complicated, it's very many times the lab could give you a subtyping of the Candida that could be mistaken and could be not accurate. And it could be spread pretty easy. So again, started in Japan, 2009. It didn't take long until the Western world has been infected. This is again the cases to it. It initially came into New England area, New York, and then it spread west. And the same thing, it shows this time frame. It shows you like the spreading until it arrived to the US in 2016. And here we did have Candida auris. It has been for a long time limited more to the East Coast, the central portion or states, and then California start coming back. These are the 3. For fungus, usually it's much different from bacteria, right? Bacteria, you have different antibiotics. Fungus, usually you have 3 main antifungal treatments. You have the fluconazole or the azole, triazole antibiotics. This is usually comes in an oral form. And the resistance for these, it has been pretty unique. It's usually very resistant. And then you're stuck with treating with intravenous medications for these organisms. So echinocandins and polyenes. And if you have somebody who had Candida auris, there's a chance that this could go, since it's a skin organism, it could go to the bloodstream and it give you fungemia, and this will have very high mortality rate. Similar type of patients are at high risk for Candida auris, similar to the other resistant bacteria. And as I mentioned earlier, it's usually to identify a Candida growing in some bodily fluid, urine or sputum or blood. Sometimes it could be mistaken for other Candida. And usually it requires these molecular testing to be done. Many times they're not available. In the big hospitals, they have them, but this is kind of the 2 main ones that could correctly identify these organisms. Colonization, as I mentioned, leads to transmission to other people, especially by contact and potential infections. And if you look at this, like for how long the colonization could last, and this shows you that these patients, nobody really knows. There's different patients could have different way of transmitting this for a long time. And that make things kind of a little bit complicated for how long we have to keep these folks isolated. More importantly than this, that this is environmental organism. It could infect, your bed, the chair, whatever you have in your room. So whatever available here could be potentially a source to infect other patients who come back to this room or share the same space. And if you look at the disinfectants that we typically use for MRSA, just the dot line, and the one we use suddenly for all these Candida, including Candida auris. And you see there's a big difference, that the typical disinfectant that you use to clean the room after the patient leaves or in a hospital setting, it really doesn't work for the Candida organisms. You could clean the room, the standard disinfectant, but that doesn't mean that these organisms are killed or disinfectant. They still could be present, and you require some novel disinfectants to get rid of them. So for some time, the screening, who should we screen for Candida auris? And I mean, the close contacts, definitely those high risk. Somebody comes in and they have been hospitalized somewhere in another country, those should be also isolated, should be screened, because you're having much higher chance for them to acquire some multi-drug resistant organism in another country. And typically, if you have somebody who's colonized or infected with one of the other multi-drug organism, those folks are probably at higher risk to acquire Candida auris as well. So in general, it has been like, if you're having a case of Candida auris, you should try your best to see who's the higher risk contact, and those folks should be screened. For a long time, there has been more push that every hospital should have the capacity to find if this is really Candida auris or it's not. And if you look at this slide from LA County, that when you start testing folks in the nursing homes, look, this is one nursing home where they did not have any testing method to start with. These are long-term acute care hospitals. So you could see the orange column is mainly a nursing home that they had a case, and then the case lingered there for some months and months to go. And then when they started testing, they were proactive in testing higher risk patient in the other nursing home. This one here, it did stop. So many times it becomes a little bit anxiety provoking, like when we tell a nursing home or ventilated SNF, you should start testing for this. And somebody will say, hey, why I have to test if I don't have it, right? Why you have to open this Pandora box and get the public health to investigate and so forth? Well, guess what? If one of these residents has it and it's really undiscovered, and let's see this patient end up going somewhere and they discovered because they're sick, they have confirmation they have it, it's going to be that orange one. It's going to linger for some time because many people has been infected with silent spreading. And this one here, it shows you like the progression of the Candida auris in Southern California. So Orange County was the first county to have 2019, the first case. It didn't take long before it spread to LA and other Southern counties. And then, hey, it didn't take long before we start seeing it in Contra Costa, Sacramento, and most recently in Fresno. And the question that comes in, why the healthcare workers, they don't need to be tested? You know, typically, as I mentioned, the higher risk folks to get tested, or the individuals or patients, are mainly the folks that disabled, they have lines, they depend on others for bathing and for feeding and so forth. You, me, and everybody else, I mean, hey, you wash your hands when you go to the bathroom. Hopefully you wash your hands before food, you take a shower once or twice a day. So even if you have this organism, because you touched that patient who's unknown to have it, and now suddenly you have it in your hands, we are much more different from somebody who is bedridden and had wounds and had lines. And so it does make sense when they tested, they did big testing on healthcare workers in the nursing homes with outbreaks. Really, healthcare workers did not have, they have very low rate of acquiring this colonization, and nobody can die from it. So this is different from COVID, where potentially everybody could infect anybody. Here you're looking for healthy folks, could be just simply a vehicle to transmit this between other residents at higher risk, rather than themselves to get long-term colonization and infection later on. And then I will jump to the precautions that usually we had for some time in SNFs, and then I will talk at the end about the Candida auris particular one. So for a long time, the main the main precautions or PPE in a nursing home or in a hospital setting has been mainly about three types of precautions. The contact precaution, the one that we're concerned here, is mainly you're having somebody who has known infection, C. diff, scabies, norovirus, So this patient is known to be infected. They're sick with this particular organisms. You put on contact isolation. Everybody who goes to the room, they have to put gown and gloves. They have to wash their hand or use the alcohol gel and so forth. They usually require dedicated equipment. And the minute this infection is over or duration of infectiousness is over, then you take these contact precautions out. Problem applying this to a nursing home with these MDRO, there are different really downsides to it. Number one, hey, not everybody who's colonized with these organisms or who carries these organisms are sick from it. If you cannot wait for the sign and symptoms to put somebody on isolation, it will be probably too late to do this because, as I mentioned, 75% of these folks in the nursing home are really colonized but not showing signs of infection. And then defining the duration, like for how long you have to put somebody who had C. diff or scabies or MDRO, it will be different, right? Depending on the symptoms and so forth. And more importantly, like even if the symptoms are, you treated somebody with UTI who had CRE or CRAP, these patients, they continue to be potentially infectious, although at slower rate compared when they were infected and sick from that organism. So the bottom line for this, colonization does not equal infection. Colonization is a slow spreader. People look healthy. Unfortunately, they are not on any typical isolation to prevent the spreading. And the duration for these folks with colonization is pretty prolonged. And residents could spread this in these organisms, and they look healthy, and they are not really infected with it. So the new kind of method of to stop the spread comes to this difficult situation where how long you have to keep these folks in isolation, and this comes with the burden of simply somebody goes to a nursing home or SNF, they're going for physical therapy, hopefully for short stay. And if it's a long term, it becomes a little bit more complicated. So keeping somebody in isolation, contact isolation for a long time, simply you're having a private room for that patient. It's very high burden on the SNF to have private room for everybody. The depression and the psychosocial well-being of the resident becomes a jeopardy here, and the stigma, right? Anytime you have a sign on the door, sometimes this could lead to depression because of the stigma that comes with it. On the other hand, you kind of look also for the safety of other residents, right? If you're having somebody who's infected and needs to be isolated, and bringing somebody to the nursing home, that's somebody also, it's a public health. So to contain the spread of these organisms becomes also an urgency. So now we come to this new approach, which is mainly to find something in the middle between having the liberty and freedom and well-being of the resident and minimizing transmission to other patients. And this is where the CDC in 2019 came in with this enhancing barrier precaution. Here in the state, in California, we call it enhancing standard precaution, ESP. So it's kind of the same, different terms, but the same concept. And this is the link that you could look at it later, but enhancing, this is mainly the standard precaution. As you know, for a long time, you have somebody who comes in with wound, they're not infected with anybody, with any organism. The standard precaution has been, you're changing the wound, dressing, you're changing a catheter, you put glove, and you put a gown on. And then when you're done with that, nothing more, right? This is standard precaution. The enhanced standard precaution is not mainly doing this when you're dealing with an open wound or changing a catheter. You're doing it mainly with any contact with the patient. And that sometimes could be much more activity just than changing dressing or dealing with exposure to bodily fluid. So here you're looking at different activities that will range from dressing to change the linen to clean the room or the devices that has been used on this patient. And by looking at this slide, this could give you an idea why like contact with these high-risk patients will lead to transmission. So they did this study, and they found that if you had gown and you had glove, this is a healthcare worker, a nurse who is gowned and gloved, and they go, and this patient with MRSA, you could see that when they tested these gowns afterwards, they found, and these patients, again, you're doing some usual activities, contact with the patient that ranges from dressing to changing linen to toileting, that you have high numbers, about 40% of them, they were infected. The gown was still positive. They had the MRSA. So you see there's large number of these gloves and gowns. They had the MRSA on it, and this potentially could lead, hey, if you don't have a gown, you could have it also on your body, right, on your hands. So if you kind of move between these patients without having gown and gloves, this gonna definitely lead to transmission to other patients. Again, this is with doing a daily contact without really providing a medical care in the sense of wound dressing or changing catheters. The same thing with these gram-negative, the one we're talking about, the CRO or CPO. So showering, I mean, some big numbers here. So you shower a patient who had it, the chances for you to have this particular organism on the glove will be much higher. So here comes the concept about why we're using enhanced standard precaution. Who should be mainly candidate for it? Number one, if you're colonized with any of these organisms, then those folks should be on enhanced standard precautions. You have somebody who was in the hospital with UTI from Candida auris or a CRE, they go to the nursing home. They don't need to be on contact isolation in the sense they need to be, every time you enter the room, you have to put the gown and glove, but you need to do it when you have contact with that patient. So those are the patients, the residents that should be on these enhanced standard precaution, mainly resident who had risk factor to acquire these bugs, dwelling devices, PICC line, catheters, and some of those folks might be not candidate or might not be high risk last month, and now they have a catheter or a PICC line. So this mainly is anytime you're doing any changes, medical devices, you should do a gown and glove. So that include morning and evening care, toileting, wound care, etc. And these are the patients that higher risk to acquire these infections. Again, these are patients who are not confirmed to have this MDRO, but they're at higher risk to it. And we're treating them that they have that particular organism. The state CDPH, they have this 6 moments where you consider these are high risk activities with these that potentially if this patient had this MDRO, these activities should be treated with the ESP. So morning and evening care, dressing, bathing. Number 2, the toileting, changing incontinence, briefs, diapers. Number 3, changing the catheters, providing medical treatments, feeding tube, and etc. Wound care. Moment 5 is mainly using the, this is when you're transferring the patient out of the room. And number 6 is much more when you clean the room. If the patient moves back to home or they go to a dialysis unit, the environmental folks will need to put gowns and gloves. So enhanced standard precaution is mainly you're treating every resident space as a separate room. So if you're having a multi bedroom, then each space should be treated like this is a separate room than the other one. You should definitely change. You cannot just have a gown and glove with patient A who's in the same room with patient B, and you move to that patient with the same gown and glove. This is, as I said with the previous slide, this is high risk potential transmission there. So it's important. I think many folks on the call are administrator and get nervous with this plan, but it's important for the leadership of each SNF to understand that this new method of stopping potential transmission of undiscovered organism in these high-risk patients will definitely save potential transmission, save lives, save outbreaks, and important to implement it because down the road could lead to relentless outbreak and more burden on contact precautions and so forth. It's important for each facility to have infection preventionists, to be well trained, and I think there's definitely different courses that has been in the work to train about these precautions, education about the staff, the hand sanitizer to be available, the folks who clean the room to be trained, and much more importantly is just to train. It's easy for us to put a sign saying do this and do that, but if they're not followed, that would become a problem. And patients with MDRO, as I said earlier, many times any skilled nursing facility get very anxious about accepting patients with CRE or CRAP or Candida auris. But these patients are, if you're accepting somebody with C. diff, with MRSA, it's the same concept. Those folks do not require really, if the minute the active infection is over, they don't have open wounds and so forth, they just simply move to the enhanced standard precaution. They don't require really a higher level of care. This is not COVID. They are much more colonized, and you're doing your best to stop transmission to other folks. So if you're able to take care of a C. diff patient, if a COVID patient, those patients should be the same. And this is kind of a link you could look for mainly adherence for how much is followed. So again, enhanced barrier or standard precaution should be used if the patient is already infected with these organisms, or if you have high-risk patients who are not known to have these organisms, but potentially they're high risk, they should be treated the same. And contact precaution, which is the one where you have gown and glove every time you come into the room. The patient stays in his room, doesn't leave the room. This is much more when you're having active infection, you're having somebody with active diarrhea or any bodily fluid that could spread it to others. Those patients should be in contact isolation. So contact is much more for active spreading because you're having an open wound or diarrhea. When these conditions are over, then they move to the ESP. Again, this summarizes the difference between the two. And when do we do the enhanced barrier or standard precautions in these activities that I discussed? And again, the difference between this, the most important difference is enhanced standard precaution does not require a single room, does not require restrictions and physical therapy and activities and so forth. So this is much more something in the middle. You're changing, you're having contact with the patient, you follow the gown and glove. But this patient does not need to be in his room, does not restrict his activities compared to the contact isolation precautions. This is the same. It's important to have all the alcohols and soap and water available to these healthcare workers when they enter the room. The medical equipment, important for these to be also to be treated in similar fashion, and then the practice to make sure your healthcare workers are following these. So we'll move quickly to the Candida auris in the last 5 minutes. Candida auris, now we're in Fresno, we're at new identified case. We're in phase 2. We had our first case just a few weeks ago. So here it's this is kind of where it's proposed for each county, what they have to do if they have a case already identified. Having a first case does not mean we have just one case and we're trying our best to prevent the second case. Having a case, meaning you have other cases that are undiscovered, and you have to do your best to simply identify it or to take precautions for high-risk patients not to acquire it. So the most important thing here is like any patients who are going to, in Fresno, we don't have long-term acute care hospital, but we do have ventilated SNF. Those folks in this ventilated SNF will need to be screened for Candida auris because they're high risk to acquire it. And anytime you're having any case identified in a nursing home or in a hospital, usually there's contact tracing where we test higher risk exposure. And of course, this stuff that usually done regardless if you have a case or not, which is mainly stewardship, follow invasive infection protocols, and so forth. This was sent in recent health alert to all the facilities about active surveillance. It's mainly if you're having people coming from VSNF, ventilated SNF, either they're ventilated SNF residents in that facility, they should be screened, or if they go to the hospital should screen them. It's recommended that the ventilated SNFs, not the regular SNFs, they do a routine PPS, point prevalence surveys, usually every 6 months. If patient tested negative today, you should test them again in 6 months. And new admission to that from that facility to a hospital or new admission should be screened. In Nevada state, if somebody comes in from a Nevada state where they have higher risk of spreading there, these folks should be also, if they go to the hospital, to be tested and screened. The Candida auris requires usually if you have somebody admitted, again, in acute care hospital, they should be in contact isolation because they're higher risk to spread it to other folks. And SNFs usually is enhanced standard precaution if they don't have any open wound or diarrhea or active infection. Most important thing, again, we did this with COVID, right? Do not use or extend use of gloves and gowns, because as the other slide showed, if you have 40% of the gowns still contaminated, cross-contaminated after any contact, this could lead to more spreading. This is for dialysis. I'll move quickly, and this is for assisted living. You will share these slides, so we'll have more the links. And surveillance for Candida auris. Usually, if you have any Candida growing, especially in the hospital, you should try your best to speciate it if it's Candida auris or one of the other benign ones. And communication. This link has the form. We did have our share here in Fresno where people, patients move from one facility to another. There's no communication. The hospital will put the patient on standard precautions, and it doesn't take long before some other folks get infected because that patient was not on contact isolation when they arrived to the hospital because of the poor communication. Environmental cleaning, list P and list K are the only detergents that effective. These are mainly the one that acts against C. diff that works against Candida auris. So you have somebody in SNF with Candida auris, their room should be cleaned with these detergents rather than the typical ones. And communication to Fresno County, by CMR within 24 hours. The number for any questions, 3332. For how to test, what precaution needs to be done for that patient, and so forth, education. These are the health alert that was sent for CRAB before and for Candida auris recently. Testing for Candida auris could be done in commercial labs. Most of the CRO, CPO, it could be done in commercial labs. It could be done in public health labs, not our labs or the state labs so far, but in Washington state. So if somebody needs to be tested, reach out to us. We could give you some guidance. It's usually a swab from the skin for the Candida auris. So it's not complicated to get the swab. The issue with testing becomes a little bit of a hassle where to send it, but definitely reach out to us if you need more information. And this is some references that you feel free to click on. And open for any questions in the next few minutes.
Amazing how much material you went through, Dr. Rao. Thank you so much. And just to put a plug in, I think it's a way for our SNFs to not only provide high quality care to their patients, but also to differentiate themselves in providing high quality care and being able to tell the public and that, hey, you're providing the most the recent guidance in infection prevention by adopting routine enhanced standard precautions for patients at higher risk for these multi-drug resistant organisms. So, and if there's ways that the health department can assist and kind of promote those SNFs that are or acknowledging those SNFs that have adopted these type of enhanced standard precautions and testing for high risk individuals. We certainly want to be able to acknowledge and support that in any way that we can.
Dr. Zweifer, Dr. A, this is Deborah Christian with Health Services Advisory Group. And I'm working closely with Shantala with the CDPH. And there's an ESP training that our webinar that has been completed. You can access the recording and get a toolkit for ESP at the link that I just dropped in the chat. And additionally, there's another training that will be available for individuals that want to be a trainer and provide infection prevention training across many topics. And so I'm going to drop the link in if anyone would like to be trained in the trainer model to help prevent the spread of infection.
Thank you, Deborah. And we'll make sure to send that information out as when we send out the slides as well. So.
Thank you so much. And CMS has an initiative, and we get HSAG gets referrals for SNFs that have higher rates of infection when compared to other SNFs across the state. And there are 7 facilities in Fresno County that have been referred to us. We'll be reaching out to those particular facilities and providing any kind of technical assistance that we can through education and resources. You're on mute, Dr. Zweifer.
Just to say, it's 10 o'clock. I'm sure everyone has things to do. Thanks for everyone for joining. Dr. L, thanks for that fantastic comprehensive evaluation. We're planning to do this again on a quarterly basis. If you have suggestions for other topics, please let us know. And you can always reach out to us between meetings as well. Bye, everyone.